Good afternoon. Welcome to the second international webinar of 2021 organized by Vets and Clinics by Advance. My name is Alba Martos. I'm the International Veterinary Manager of Affinity Pet Care. And today I'm very happy to be here with Núria Vizcaíno. Good afternoon, Núria. Thanks for your time.
Good afternoon, Alba. Thank you for having me here.
Before starting, I would like to present you Núria. Núria is working as a senior clinician in the Orthopaedics and Soft Tissue Surgery Department in Ars Veterinary Clinic in Barcelona. She's a diplomate of the European College of Veterinary Surgeons, and she has a huge experience after being 4 years in Bern, completing 4 years residency and obtaining the PhD. So I'm sure that today the session will be really exciting. So I hope you are plenty of energy and you enjoy it. Before starting, I would like also to share with you that you can send during the conference your questions, and at the end of the session we will share with these questions with Núria, and we will answer all of them. But in case we do not have enough time, you can see an email below here in that screen, and there you can send your doubts. Also, another thing, remember that you can download the presentation clicking on the link you can see below too. And I think that's all. I think we can start the session. So Núria today, she will talk about the osteochondritis dissecans in dogs, its etiology, its diagnosis, its treatment. But I think that we can start the session as asking the question, what is osteochondritis dissecans in dogs? And why, Núria, do you think that it's interesting to share this issue with our audience? So we can start with, I think that it's a good question to start this session.
Thank you, Alba. Thank you for your introduction. So, what is osteochondritis dissecans, or as we know it, OCD? OCD is a disease that we see during growth. It's a disease of what we call endochondral ossification. I think it's interesting to talk about this topic because it's a disease that we see fairly frequently in the small animal clinic, mostly in dogs, it's very rare in cats. And although the disease has been described for many years now, in the last few, there have been some reports on some new treatment options. So I thought it would be interesting to go through the basics first and then review those new treatments. So what is OCD? As I said, is a disorder of the endochondral ossification. And what does exactly mean? So here what you see is a bone during growth, in which we're going to see a cartilage in the bone itself. And the ossification is going to progress in this direction. So at the beginning, we're going to have two different kinds of blood supplies to this part of the bone. One is going to come through the cartilage canal vessels that come from the perichondral plexus. And the second one is going to come through the subchondral plexus. So both of these plexus are going to be at the beginning independent. As the growth of the progresses, what we'll see is that both of these plexus are going to start making connections, or as we call it, anastomosis, between one another, right? So you see here that they cross the line both, and we're going to see connections between one another. Should one of these connections or anastomosis fail, we would end up having just a bit of this cartilage that is not vascularized, so that has no blood inflow. Now there are two possible scenarios here. Scenario number one is that this defect that we see here, non-vascularized, is rather small and gets that embedded in the bone. And because it's small and has in the nearby areas that are vascularized, this can make it heal. If the defect is rather large, then we're going to end up having such a large defect without any blood supply, and what could end up happening, or what usually ends up happening, is that we have a crack in the cartilage, and this bit falls off, and we end up having a flap, or as we call it, this part of the disease, we call it dissecant, when we have this flap breaking.
Well, many thanks, Núria. I think that now it's clear what is osteochondritis. The second question, I think that can be if all joints can be affected. there is one of the joints or maybe several joints that are most probably affected by this disease?
Well, it has been described in several joints, but not all of them. It could be that in the future we start seeing some new descriptions. For sure, the top two most common are going to be first off the shoulder joint and second off the elbow joint. Those are the most frequent places in dogs. In the shoulder joint, we're going to see it at the caudal part of the humeral head. And on the elbow joint, we're going to see it at the level of the medial compartment in the medial part of the humeral condyle. It has also been described, as I said, in other joints, such as the stifle joint, although it's not quite common. It is very common, though, in human medicine. It has also been described in the hip joint. It's quite rare. I think there's only a few case reports describing this lesion in that joint. It is a little bit more common in the lumbosacral area, so in the vertebrae. There's one case report at the level of the cervical vertebrae, but it's more common maybe in the lumbosacral, so L7S1. And lastly, we can also see it in the tarsus.
Many thanks, Núria. I think that, well, we can continue analyzing if there is any risk factor that can predispose the dogs to have OCD. What's your experience or what news we have about that?
So there's a little bit of controversy on which are the that can predispose a dog to have OCD. There is for sure a big genetic factor, and that we know for sure. The heritability of the OCD comes up to 45%, so it's quite high. So that's one big thing that we certainly know. We also know that large breed dogs are at higher risk, and actually it's very strange that we see it in smaller dogs. Sometimes it's been thought that it's because sometimes they have different number of secondary growth centers. So this could be the reason why they don't do it as often, but it's not quite clear. For sure, large breed dogs, males, and genetic factors very high on the list of risk factors. And then there's a little bit of controversy as well on how diet might affect the appearance of OCD. So there are a few studies, but mostly they're done in very specific breeds, so Great Danes mostly, in which they would give them different concentrations of calcium in the diet, and they will also play on how much food they would give the puppies. It would seem like diets with high intake of calcium would maybe predispose dogs to have OCD, and those dogs that would have food ad libitum, they would be also at higher risk. But these studies need to be read with a little bit of care, because the groups are rather small and they only target one specific breed. So we don't know if it's really, this could be then generalized to all the rest of the population of the dogs.
Okay, so now if we know that there are some specific risk that can predispose the dogs to have osteochondritis, what we can do to prevent that disease? So how we can manage and avoid, or trying to avoid, that they have OCD?
So Alba, because the only thing we know for sure is that the inheritance is really high, the first thing we can do is stop breeding with those dogs that have an OCD. That's sometimes difficult because breeders are not often clear about those, and they have and they still keep on breeding with dogs that have OCD or that have had puppies with OCD, and those dogs should be discarded as breeders. That should be the number one issue to stop preventing it. The second thing will be the diet. As we said, it's not quite clear how the diet affects the appearance of OCD, but I think that it makes sense, first off, that we think about giving puppies a balanced diet. So trying to avoid high or very low calcium intake, so a balanced diet basically. And it's also we're going to try to avoid that they grow really fast. So we're going to try to avoid giving them food ad libitum, especially in dogs that have a lot of anxiety with food and they cannot control themselves. We're going to control the food intake, not only for the OCD, but for many other problems of growth, like hip dysplasia, etc. How then about barf diets or raw food diets, there are some owners that are really keen on giving this kind of diets to dogs. I stopped opposing that. However, if you have an owner that you're seeing that has a puppy that potentially is at risk for having OCD, and they're not gonna be willing to feed them with kibble, the best thing you can do is try to make them give them the contact of a good nutritionist, because it's really difficult to give a good balance to puppies. Their needs, they change very often. So about every 3 weeks they would change their diet. So if they go this way, which is not my favorite, but still it is a way, they make sure they have a good specialist that can guide them through this nutrition. And last, there's also the debate if exercise can cause or can predispose a dog to OCD. Now, there's few studies on how trauma to the joints, even it's micro trauma, so from jumping, can affect those. And in the end, there's no clear consensus on how it can affect it. It seems like it could play a role. So since there's no consensus, what I would say is that the best thing you can do is think of a puppy just like a baby. You would not run a marathon with a baby, so don't do so with a dog or with a puppy dog. And try maybe if you're willing to do some high exercise like jogging or agility, try to start those once a puppy has grown up, not during growth.
Many thanks, Núria. I think that now it's clear. My next question is that what we will see when we have a dog in the clinic and we think that maybe that dog is suffering from osteochondritis. Which findings we will have?
So it depends a little bit, Alba. We can find different kinds of presentations. So the easiest one would be when we have a dog that we know is from a breed that could be predisposed to OCD. We're going to see, so it's a large breed dog, a Labby or a Great Dane, for instance. It's maybe a male even that they have a little bit of higher prevalence. And the dog presents with an acute lameness of one limb. So that would be what the best case scenario. However, there might be some instances we don't see that presentation. One of the cases is if the dog has OCD in the contralateral limb. So when we have a dog that has both anterior limbs affected or both hidden limbs affected, what's going to happen is that most of the time we don't see a clear lameness. Either we see a lameness on the limb that hurts the most, or we just see a dog that is not really willing to run or jump as we expect for their age, right? Sometimes it goes, the owners will report that he's going walking, and then after just 5 minutes, he sits down and doesn't want to walk anymore. So it's going to depend a lot on the presentation, on which joints is affecting and how many as well. Also, sometimes the lameness doesn't start all of a sudden, but it kind of slowly comes in, slowly progresses, and then it's a little bit harder for the owners to know when exactly it happened, it started, or even to notice that their dog is limping. And when it comes during the orthopedic exam itself, so the palpation, we're going to find mostly pain in the joints. Puppies are really expressive usually when it comes to pain. So they really show when they're painful, which is very useful in the orthopedic exam. And we're going to try to do, especially on the shoulder, on the elbow, or in the stifle joint, we're going to try to manipulate the joint. So we put pressure on the area where the OCD defect is most commonly seen to elicit some pain response. So in case of the shoulder, we're going to press the humerus against the scapula while we're flexing the joint. So that should create a pain response of the puppy. Also, if we do it on the elbow, we're going to do the same processes or the same test that we do when we check for a breakage of the coronoid process. So we're going to flex the elbow and do an internal rotation of the extremity, and that should also elicit a pain response. When it comes to the height, it's going to be probably quite difficult to know if it's a OCD. First off, because it's very rare, and then we cannot really palpate a swelling. So the dog is just gonna react on hip extension. Probably we're gonna think about first hip dysplasia, and it's gonna be the imaging that's gonna tell us that that was not the case. In case of the tarsus, most of the time we see a very severe swelling of the tarsus, and that gives us an idea that the problem is there. There's no specific movement we're going to do to elicit pain, but it's really painful in general, the tarsus OCD.
Okay, thanks. Maybe it seems that not all times it's clear to know if the dog is suffering osteochondritis or not. So related with that, I have the question, and I think that it's interesting to share with our audience. If we have to adapt the diagnostic process depending on the joint that it's affected, there is any difference, or which is your experience with that?
Well, Alva, it's a good question. Technically, you could use most of the diagnostic approaches for any of the joints. However, in some instances, some of the diagnostic tests are going to be more useful than others. So we're going to see some examples for each joint. The first one is going to be the shoulder joint. So in the shoulder joint, we saw that the lesions are going to be seen on the caudal part of the humeral head. And in this case, most of the time, we're going to be able to diagnose all of these lesions only by doing an X-ray. So we're going to position the dog in a medial, we're going to do a medial-lateral projection. And we're going to see with this projection, we're going to see the lesion on the caudal part of the humeral head, as you can see here. You can see a subchondral bone defect, so you see an irregular surface and a flattening of this head. So if you have, if it's superimposed with the trachea, that might help you as well. Here you have another example. In this case, it's not as clear as in the other one, maybe for some. So in this case, it's a bit more caudal, but you do see a flattening as well of the surface, and you see that the surface is not regular. Now, in some cases, if we do an X-ray, we still might doubt if it is or it's not. So one trick that you can use if you're diagnosing by X-rays is to do some rotation of this joint. So you can do some internal and some external rotation of the shoulder joints besides doing the neutral X-rays. So what we're gonna achieve with those images is that, as you can see here, in the internal rotation, it's not seen as clearly. However, on the external rotation, you see a clear defect of the caudal part of the humeral head that is exposed with this rotation, just as it happens in surgery. During surgery, doing external or internal rotation, we can visualize this defect. Can we do something else if we want, or if we still have some doubts if there's an OCD lesion in this humeral head? Yes, we can, of course, but usually it's not necessary. So one of them would be to do, the most common one would be to do a CT scan. So with a CT scan, we can include, of course, both shoulders at the same time, which is an advantage, and we can also include some other joints, more typically the shoulder, the elbow joint, sorry. Now, what we're going to see is exactly the same that we see on the X-ray. So you're going to see a defect, in this case, a hypointensity here of the humeral head, surrounded sometimes by a hyperintensity as well. You see it on both sides, left and right. You see here a defect that is smaller. But in any case, the fact is that CT scan doesn't bring any other information to this, doesn't add up any information to what we already see on the X-rays. So that's why most of the time we're not gonna need to do a CT scan. What if we don't have a CT scan on our clinic? Well, another option would be to do a positive contrast arthrography, like you see in this case. So we're going to inject contrast in the joint, and that's going to allow us to see not only if we have a defect of the subchondral bone like we have it here, but we can also visualize some other structures such as the biceps tendon and the joint. So what's going to happen when we put contrast in a joint that has an OCD is that this contrast is going to flow into the subchondral bone, so we're going to see it infiltrating the defect. So in case we still have doubts with the plain x-rays and the internal and external rotation and we don't have the option to do a CT scan, a positive contrast arthrography would be also a possibility for us. Now, when it comes to the elbow, things change a bit. In the elbow, they show the OCD lesion we're going to see in the medial part of the humeral condyle, as you see it here. In these X-rays, of course, I chose them because you can see it very nicely. So you see also a subchondral bone defect, which is located in the medial part of the humeral condyle. Now, what happens in the elbow is that we have a lot of superimposition of structures, and it happened just as well when we try to evaluate the coronoid process, for instance. So in these cases, although we do see it here, a lot of times we cannot really know for sure that the defect is there. And sometimes we have doubts if that lesion might be not an OCD, but a kystic lesion due to a fragmented coronoid process. So although we can see OCD lesions on plain X-rays, the tendency more and more is to do some CT images in these cases. So here you have another example where you can see it in the X-rays. So you see it on the medial part of the humeral condyle, you have a nice defect of this condyle, but you see that there are other things happening on this elbow. It looks like the radius might be a bit short, so we might have some other diseases in this elbow that might not be seen as clearly with X-rays. So in this instance, most of the time we do go and do some advanced imaging before we decide on the therapy. Now, what happens with the stifle joint? Well, there's not a lot of literature on it, and not as much as in shoulders or in elbows. As we can see on the X-rays, we do in this case see it clearly, but we might also have some cases in which we doubt if there is or not a lesion, depending on how big it is, of course. In this case, you see it here. There's a big OCD lesion surrounded by an area of sclerosis, which is typical of this disease. What happens with the hip? Well, we don't have, as we said earlier, we don't have a lot of cases described. So in case of the hip, we might see it also with X-rays, just as the case that you see here described. However, in some instances, it might be a bit difficult to see it, and in this case, probably some advanced imaging might help. The same is going to happen with the tarsus. The tarsus is a joint where we have a lot of superimposition between structures, and as we see in the images, we know there's something happening because there's a lot of increased radiopacity of the soft tissue, so we have a lot of swelling of the soft tissue, so that we know there's something going on. However, it is very hard due to superimposition to see this defect. The defect in this case is going to be at the area of the trochlea of the talus, so it gets hidden between the tibia and sometimes even the calcaneus, which is superimposed, and that makes it sometimes very hard to see the lesion. You see that there's something happening, you don't see quite what this something might be. So in this case, the CT scan might help a lot, as you can see it here. Here you see that this dog has a bilateral disease, right? So the trochlea of the talus is missing a little bit. You see some fragment right there, plus the soft tissue swelling. So it really adds a lot of value to the CT scan in these cases.
Many thanks, Núria. I think that now we have detailed information about how to diagnose OCD. So now it's time to move to the treatment. And the first question I have is, which is the most common treatment that we have for this disease? If you can explain us, which is your thoughts about that?
So the most common treatment is going to be debridement of the lesion. That means that we're going to remove this cartilage flap, and we're gonna debride of the recipient area. So the idea behind this technique is we're gonna try to bring some mesenchymal cells to the area so that they cover all the recipient bed, and with time we hope to have some fibrocartilage in the lesion, covering this lesion area. We're never gonna have articular cartilage growing back spontaneously again, so we can forget about that. But we're going to stop having contact between the upper cartilage and the defect. So that's going to help with the pain, and by covering with fibrocartilage, that's going to ease as well the process. This we can do with arthroscopy, as you can see it in this picture. So you can see with some small instruments like this curette, we're going to scratch or debride all the area where we have this flap falling off. We're going to see the edges. We want to see the edges of the cartilage being homogeneous, so not having a very thick cartilage, which is usually part of the lesion as well. The same thing we can do in all joints. Here you see an elbow. So this is the medial part of the humeral condyle, and you see a large OCD defect that's falling off. This is a cartilage falling off. So we would now enter with the curette, as we saw earlier, and debride all of this bed to make these mesenchymal cells come out and cover then with fibrocartilage this area. We can do, not only we can do a curettage with the curette that we saw earlier, but there's also described some other techniques, like with pigs and owls, but the idea will be behind them is exactly the same. So we're going to see that we're going to try to bring some mesenchymal cells to the area. Now, some people say that if you do such kind of, if you use such kind of instrument, you might impact the bone, and you're not going to have so much bleeding. But you can see what you prefer the most when you're doing it. Now, here you see what we did. We debrided the lesion on the medial compartment of the medial part of the elbow joint. Sorry, you see you have some bleeding of the area, so that's going to be our goal, right? To bring the mesenchymal cells here and cover the defect. This we can do either with arthroscopy, but we can also do it by arthrotomy. It's a little bit less elegant, but it's doable. In some joints, it's going to be a bit more difficult, but what we see here is the shoulder joint, which has a relatively easy approach to it. So you see here on the left side, you see the caudal part of the humeral head, and you see a line that separates the cartilage that's normal from the defect. And after debridement, you can see here that you have a huge defect that we have debrided already, and it's bleeding. So doing it by arthrotomy is also an option. In case of the elbow joint, it's a little bit more complicated because you're not going to see it as nicely as you see with the arthroscopy. But if arthroscopy is not an option, but arthrotomy it is.
Thanks, Núria. So I think that now it's clear which is the most common treatment. But adapt, I have it. Okay, if we do this treatment and it does not work, which other options we have to treat OCD in our dog?
Yes, so we do have some options if our first line of treatment fails. So if the debridement is not enough, or if the dog keeps on limping, or if the dog is not a good candidate for such a treatment. So here you have some examples. One of them is the osteochondral autograft transfer. What means is that in this case, we're gonna, since we said that when we do a debridement of the lesion, we're never gonna have articular cartilage growing in that place again. So we're just gonna have, in the best case scenario, we're gonna have fibrocartilage growing. So if we wanna have articular cartilage growing or in that place again, in the lesion, covering the lesion, one option is to transfer it from elsewhere. So in this case, as you see it, we can transfer it from another joint. Usually it's described from the stifle joint, so we're going to remove cartilage from a stifle joint that is sound, that doesn't have any lameness. Usually we take it from places where there's no contact with other cartilage, so as you can see it here, right? we're going to take those pieces and we're going to implant it in the place where we had the defect, as you can see it on these images here on your left. So this has, of course, some advantages and some disadvantages, as you can imagine. So the first advantage would be that you're going to have articular cartilage growing back into place again, but in order to treat a joint that is not normal, you're touching a joint that is normal. So you're going to have to expect some osteoarthritis in the stifle joint that might not be in most cases significant, but you're going to have it. In some case, you could have some complication on a stifle joint that was sound to begin with. Now, in the shoulder joint also, you're going to have to replace the articular surface, and you're going to have to mimic the surface that you had before, which might not be so easy because you're taking it from an area that's not exactly the same. So you're going to have to reproduce with several grafts most of the time the surface that you had that mimics as closely as possible the original surface, which might not be easy. You can see that this it's in a way it's good because you're going to have the articular cartilage growing, but the fact that you have to touch a sound joint to fix another one kind of make people that start looking for alternatives, so we would not have to operate in a joint that was sound. So here you have one of the alternatives, but the idea behind the surgery is exactly the same. So in this case, what we did is we take a synthetic graft. So this is not, this doesn't come from the joint of the stifle joint. So this is an implant that's gonna replace this cartilage defect. So we're gonna put this implant instead in the position where this flap fell off. Now the advantages, of course, is that you're not gonna touch any sound joint. But the disadvantage is that this is not articular cartilage, of course, and this is an implant, so there's always a risk for infection, which you probably would not have if this was from the same patient. Now, these implants have some advantages over time because they have some porous surface which gonna allow bone ingrowth into them. So with time they're meant to be very stable because once the bone grows into it, they're meant to be to hold very good and to be less likely to get infected. However, it's still an implant. So there's always a pro and con for each treatment. In this case, we see that not touching another joint might be a good option, but you have to consider some other complications that might develop in the future. Another option that has been described for the shoulder joint, in this case, was described also for osteochondritis, so it's not for another disease. It's the ME arthroplasty. So we're gonna do a partial joint replacement, as you can see it here. It comes from the idea from human medicine, and in this case, it's done in a dog that has a very large defect on the area. We don't know if that dog would have done well with the debridement treatment. However, in this case, the clinician decided that the defect was very large, and they replaced the area with an implant. The same as we said earlier, with the other implant, we always have the option to have, or the possibility to have an infection or a loosening of this implant, which is something that we're not going to see with other techniques. However, if you have a very large defect, well, this is a good option. Or if the dog is not doing well, with our first line of treatment, we can always consider such an alternative. Now, what happens with the elbow? We do also have some alternatives in the elbow joint. You are seeing one of them here. This is called Q, and it's basically a partial replacement, a partial joint replacement. So it has two components. One of them is going to cover the coronoid area, and the other bit is going to cover either the OCD or if you have a kissing lesion area. So it's not really thought specifically for OCD, but for all the lesions that we have in the area in the case of the elbow. So in this case, this implant, we had a lot of issues in the beginning, especially with the positioning. However, with time, there's some new approaches that seem to help a little bit with the outcome. And it's of course a good option. The only thing is that it's a little bit, it's not a big implant, so the defect and the implant, they kind of have to match. So you can always enlarge the defect, but you cannot enlarge the implant. Do we have more options in the elbow? Yes, we do. As you can see here, some other options, if Q is not an alternative, it would be to replace the whole elbow. So we have elbow replacement. Here we have the option of biometrics, which is one of the prostheses that we have now in the market. Now, the thing with the elbow replacement is that it doesn't work as well as it does with in the hip joint, and there's a lot of room for improvement. So in the following years, probably we're going to see these implants coming in the market strong. However, at the time, although there are a few clinics that place them, they have a lot of complications, and the outcomes are not as good. So most of the time, we still use it as an alternative or a second line treatment, or not the first one for an OCD. But if we have some developing osteoarthritis and there comes a point where we cannot treat them, this would be also an option. This is another alternative, also total elbow replacement. In this case, is another kind of implant, but the idea is exactly the same. So in this case, it's the Iowa state. It will be in cases most of the time not as a first case, or not as a first time line of treatment. Will be for cases that have developed some secondary inflammation and osteoarthritis of the elbow joint, where we cannot treat medically. Then we can think about putting some of these elbow replacement implants. In case of the knee joint, we do have some alternatives as well. You can see it here. It's exactly the same we saw on the shoulder joint, where we can replace the area of the defect with a synthetic graft. It's exactly the same principle. We're going to have some bone growing into the implant, and that's gonna make the implant more stable. And as we said, the good is that you don't have to take cartilage from elsewhere. Although here you could take it from the same stifle joint, so you would not touch a sound joint. You could take it from the same one and replace it on the area where there's contact. But on the other hand, you can place this one, and if you place an implant, you always have the risk of having an infection and not being able to get rid of the infection while the implant is in there. Another option, usually not the first line of treatment, is total knee replacement, as you can see here. So instead of just replacing the area where you have the defect, you could replace the whole stifle joint. Now, this is not used usually as a first line, as I said, but it's usually when we have an evolution of this lesion over time, and we have a lot of osteoarthritis, and we cannot treat it only medically, then we would replace it. We would replace the whole joint to get rid of the pain and give the patient a better quality of life. In the hip joint, there are not a lot of cases, as I said earlier, so we cannot tell how good or bad they do as a group in the future. However, if we would try the first line of treatment and that doesn't work, we could also always think about the total hip replacement. In this case, it works really well. Docs do they do bear weight from the day one, and they do really, really well. So this is a really good option in case of having an OCD in the hip joint that either we didn't see or we do see and it's not working. The patient is not a good candidate for the first line of treatment. And in case of the tarsus, if the first line of treatment doesn't work, we do have some alternatives. Most of the time will be to do an arthrodesis. So by fixing the joint and removing the cartilage surfaces and ossifying this joint, we're gonna at least get rid of the pain or be able to manage this pain better if the dog is not doing well. So it's not a very elegant option, we have to say, because the dog is not going to have any movement of the joint, but they tend to be quite painful in this area. So at least we're going to be able to manage this pain. So arthritis is certainly an alternative. Once we have done debridement, and if the dog is not doing fine, we can always offer this option to the owner.
Really interesting, Núria, to see the options we have for different joints. The next question I have, it's related with the treatment. If we debride the joint, this joint in the future can have osteochondritis, or just with the treatment it's completely solved and we don't have to suffer for that joint again?
So certainly this dog, when we do a debridement or when we have a lesion, let's say on a joint, we can know for sure that the dog will develop osteoarthritis 100% of the time, right? So only because the dog had the lesion, we're going to see osteoarthritis developing. Now, that does not mean necessarily that the dog will be limping or will have chronic pain on that joint. Sometimes they don't. Even when we do X-rays, we do see that that there are some osteoarthritis building up. So 100% of the time, we're going to have osteoarthritis on the joint, and that's something that we need to discuss with the owner before the surgery itself, so that they understand it is not only the surgical fault, but it's also the nature fault, right? Only because the lesion is there. Now, since we know that the dog is going to develop osteoarthritis, we might already introduce the owners on the basic of treating this osteoarthritis. And we're going to see three main things that we have to take care of. First off, we're going to talk about them seriously about weight, because we need these patients to be on the right weight for life. Not only for the surgery, not only for the recovery, but for life. We need those patients to be rather on the lean side, not on the fat side, right? This is gonna affect the most to their outcome. So when they're lean, they walk, they don't have that much weight on their joints, and they walk better. So it's really, really important that they understand that. And even if it's in a joint that usually does well, when we have a lesion, it is important that they still have in mind that the weight management is really, really important in these patients. Now, the other one is going to be rehab or physiotherapy. In some cases, we have to consider these patients might need it just after surgery or even for life because of the osteoarthritis that builds up afterwards. And third, and not less important, we have to consider that these patients might need some kind of analgesia, either for a while or sometimes for life. And we also usually talk about multimodal analgesia because we're going to try to give them a combination of things that makes us that allow us to bring the doses and the frequencies to the minimum, and then we can also diminish the chances of secondary complications due to these drugs, and that's going to also help us that they'll do better without, or they can have a good quality of life with their arthritis.
Thanks, Núria. Well, I think that we can move to the last question, to the last part of this session. And I think we can talk a little bit about knowing that this disease is maybe for all life, or quite sure for all life. The prognosis we have for the dog is different depending on the joint affected, or what do you think about what we can expect with that dog that is suffering OCD?
So the prognosis, certainly, Alba, is going to change depending on the joint that is affected. That's for sure. So the best scenario here is having an OCD in the shoulder joint. The shoulder joint is the one that is going to give us the best outcome with surgery, usually only by debriding. In the studies and also by experience, I can tell you that the prognosis in most cases is really good. So dogs do very well afterwards, and even if we do see some osteoarthritis on the X-rays with the X-ray in the future, dogs, they don't show this osteoarthritis clinically, so they're not limping from this joint. So owners, they tend to be very happy with the outcome, and so do the dogs, of course. Now, when it comes to the other 3 joints that we saw today, the prognosis is not as good. So in the elbow, for sure, that is where we have most studies. I would say best case scenario, we have a good prognosis, but in some cases it's going to be fair to poor. It also depends on how many other lesions do these dogs show in the elbow, because we said they can have other lesions associated, such as fragmented coronary process, or they can have incongruency, etc. So that's going to give us sometimes a hard time making these dogs walk normally and being pain-free. When it comes to stifle, the prognosis is also thought to be guarded to poor. So these dogs are not going to do very well, and probably those dogs are going to be now candidates to those new treatments that we talk about, where we can replace the area or replace the whole joint to make them pain-free and have a good quality of life, although there are not a lot of studies because stifle OCD in dogs is not that common. And the same happens with the tarsus. The tarsus, the prognosis is not going to be very good. It's going to be, best case scenario, I would say, fair. Of course, there could be some that reacts well to treatment, but most of the time it's going to be fair to poor. Dogs, they have a lot of pain in this area, and even if we did right the lesion, most of them, they will be needing treatment for a long time or even for life, to diminish the pain that they are feeling or in the lameness. And in case we cannot get to control this pain, some of them are going to end up getting tarsal arthritis, so at least they are pain-free. Here you see a dog that has a bilateral tarsal OCD, and you see that he's heavily limping. There's quite a big deformation of the tarsal joints, and he's not really doing well. The issue here, as we talked in the beginning when we were seeing the ortho exam, is that if only of the tarsal joint is affected, we're going to see a severe lameness. But if both are affected, so you see the bilateral disease, then probably it's going to be a dog that is not willing to play as much or run as much, and we don't have to only see the lameness as a sign of pain, but also the lack of activity as well. So they are very young dogs. So if we're not seeing that they move as they should, the lab, usually a lab of a puppy, is a very active dog. So if we're seeing that they're not moving as much or not doing as activity that we expect, probably is because of pain, and then we should consider treating it. So unfortunately, not the same prognosis for all the joints.
Thanks, Núria. I think that it has been a really exciting session. So, well, we are at the end, but we will keep connected because we have been receiving some questions during the conference, and it's time to answer them. So don't disconnect. We will be here in a few minutes. We are here again. So, well, we will share with the audience the first question we have received. It's related with if we have a deformity in a limb, for example, that it has been described in humans that it predisposes to the OCD. So it's the same in dogs. There is any study that correlates deformity in the limbs with OCD, or which is the news we have for dogs?
So Alva, is not quite clear if it happens the same as it does in humans when they have deformation of the stifle joint in humans mostly. In case of dogs, it's thought that the hyperextension of the tarsocrural joints may be predisposing to it, but it has not been proved. And there's also the theory that maybe elbow incongruity may be one of the reasons why dogs develop osteochondritis in the elbow joint because of having an incongruency predisposes the weight not to be balanced between radius and ulna. But to this time point, it's only theory, so we're not sure it does affect.
Many thanks for your answer, Núria. Let's move to the second one. The second one is about if we have a case with OCD in spine, which is the diagnostic and how we can treat this kind of OCD. Can you share with us your experience?
Yeah, sure. So in case of OCD in the spine, mostly, first off, we're going to see, which I didn't say before earlier, is that it might present only with pain in the area, which or we can have some neurological deficits in this case. So sometimes we could have it. It could be difficult to differentiate it with with some hidden limb disorders. Now, to diagnose it, we could have a suspicion on X-rays, but most of the time before we decide on treatment, we're going to go for advanced imaging. So it's going to be best case scenario, we would do a combination of CT and MRI, so we can do the bony part really well on the CT scan, and we can see the soft tissues of the spinal cord with the MRI, which would be the best case scenario. In case we don't have these options, so CT scan would probably do before we decide how to approach it. And then when it comes to treatment, we would, depending on if it's a single lesion, we have other things. We most commonly remove the fragment via a dorsal laminectomy.
Thanks, Núria. Well, we are out of time, so I think that we have arrived to the end of this session. I hope you have enjoyed. I think that it has been really, really exciting. And well, on the one hand, thanks, Núria, again. And on the other hand, just for our audience, remember that we will come back next month with more webinars. So we hope to see you there. And thanks for your time. Thanks for being here with us. And well, see you soon. Bye-bye.